because we're going to be doing a lot of backwards and forwards. So let's go through the first case. I guess is the one you want. This one over here, correct? That's the one you want to go over. Okay. So she's a 75-year-old, gravida 2, para 2, stage 2 utero. And again, I'm seeing this for the first time. Stage 2 utrovaginal prolapse with a cystocele and a rectocele. You did an abdominal supracervical hysterectomy, BSNO, sacrocolpopexy with a perineurography and cystoscopy. Pulled out a uterus weighing 32 grams. Endometrium was benign. There was a polyp which was benign. Endocervix normal. Bilateral tubes normal. Failed avoiding trial, 1-day stay. Okay, so we all understand the case. So Ashley, let me start by asking you, do you have any concerns about this case?
No.
Okay, fine. The fact that she had a failed voiding trial, does that bother you at all?
It's something I would be prepared to talk about.
That's what, when I say bother, understand the way I put, does that bother you? I'm not trying to make you second guess yourself. I just need to understand, as we're doing this, I need to get myself as much as I can into your head. So that's why I'm asking these questions. Okay, so you've got no concerns with this case. Fine, perfect. I'm just going to raise two minor concerns, and we'll come up again to this issue later on. The first one is, why did you not do a total? And the second one is, why did you do the cystoscopy? Are you comfortable to address those two questions, Ashley?
Yes.
Okay.
In my practice, I do a supracervical hysterectomy in order for when I place the mesh for the sacrocolpopexy, it has a much lower rate of mesh erosion into the vagina. It's about 3 times lower. So that's why I choose to leave the cervix. And this patient had no history of cervical precancer or abnormal pap smears. And then as far as the cystoscopy.
And I'll just pause you there for a moment, and I'm going off at a tangent because this is my bent. This is my personal pet subject. When you say I did it as a supracervical because of this reason, as the acting examiner, I would love to hear you say, but normally I will do a total, because that's really, we want to go with the most standard procedure possible. You have a very real reason for doing what you did in this case, but you want to make it, you want to give the examiner what they generally are expecting to hear. So I would have added that little extra bit. But if this were not the indication, I would do a total because I think it's preferred. Just add that verbally. Okay, the second part.
For the cystoscopy, after placing the mesh in this case, I perform a cystoscopy to make sure that I haven't kinked the ureters or put a stitch too close to the ureters. But if I wasn't worried about that and hadn't been near the ureters, I wouldn't have done a cystoscopy.
Okay, perfect. I'm totally comfortable with those issues. Now, Ashley, in fact, I need to get a piece of paper here. My question to you is, in a perfect world, what questions would you love the examiner to ask you that is such that if the examiner asks you these questions, you're in great shape? You're going to score big time and impress them big time. So what are the questions you would love to have?
I'd love to talk about the stages of prolapse.
Prolapse staging,
I'd love to talk about alternative treatments for apical suspension.
Alternative treatments, apical suspension, yeah.
Why I may or may not have done a sling procedure at the same time.
Pros and cons of concomitant sling. Yeah?
Yes.
Okay, anything else?
And how I managed the failed voiding trial, or what that signifies for me.
Management of failed voiding trial. Okay, and that's it, or is there anything more?
That's it.
Okay, let's take the first one. How can we word your case in such a way that the examiner will want to ask, well, tell me about staging, okay? I'm just throwing this out. Feel free to disagree. And Lindsay, again, this is where you come in as well. We can do stage 2/3 uterovaginal prolapse, okay, with a question mark. Lindsay, if you're the examiner and you say stage 2/3 prolapse with a question mark, I don't want to put words in your mouth, but I'm going to. Would that perhaps induce you to ask a question? Well, was this 2 or was this 3, and what's the difference?
Yeah.
What,
Yes.
sound reasonable? Please don't say it just to agree with me. Only if you absolutely believe it, okay? But that's okay. All right. So that's one option. What about another option, Ashley? Uterovaginal prolapse, symptomatology inconsistent with staging. What do you think of that?
I like that.
Lindsay, if you were the examiner and you read this, prolapse, symptomatology inconsistent with staging, wouldn't that induce you to start a conversation? What were her symptoms? What were her staging, etc.? What do you think? Again, feel free to disagree.
No, makes sense.
Okay. So, Ashley, to you, which of the, I mean, I just thought of 2 now. If either of you can think of a third option of how to address this, then, let me know. But of the 2 that I've offered so far, which would you prefer, Ashley? Which one sits better with you? But let me prefix. Are you comfortable with either of these 2? What's most important of all is that you should not accept anything that I say that you're not comfortable with, because that just won't work. So you've got to be comfortable. Which if either of these 2 would you prefer?
I like the second one. I think if I said, 2/3 question mark,
Uh-huh.
it's kind of an objective finding, so I'm not sure.
Okay, I hear you.
Yeah.
So I'm going to change this, as you see here. You can see it as I'm doing it, yes?
Yes.
So uterovaginal prolapse, symptomatology, excuse the cat crying, I'm going to kick her out the room in just a moment. Symptomatology, inconsistent, is that the word I said?
Mm-hmm.
Inconsistent with stage. Yeah? Or grade,
Yes.
I should say. Grade or stage, which is the better one?
Stage.
Stage, okay. Just clean that up. And by the way, I'll be happy to mail this back to you afterwards. So if you don't have to worry about writing it down. So how does that look now, Ashley? That's okay?
Yes.
Can you see how much we've already increased the probability of you getting that very first question that you wanted? Yeah?
Yeah.
Okay, good. Let's move on to the second question. Alternate options of treatment for apical suspension. Now, be a little bit more specific for my benefit right now. Where do you want to go with this conversation?
Why didn't I choose to do a vaginal procedure with either a sacrospinous or a uterosacral ligament suspension?
Okay. Are you comfortable to talk about those alternative options?
Yes.
Okay. So, abdominal so you did a sacrocolpopexy, correct?
Yes.
Instead. Um, what about putting in parenthesis after there either the word preferred or sacrospinous, sacrospin lig, I want to be abbreviated, suspension, contraindicated or not feasible. Do you understand what I'm trying to get? I'm trying to introduce something that will induce the examiner to say, well, why was this preferred, or why wasn't that, why was that, or use the word suboptimal. What about, first let's talk about the principle that I'm sharing with you now, Ashley. Are you comfortable with the principle?
Yes.
Okay. And so which of those options would you prefer?
I like the preferred in parentheses.
Okay. Lindsay, what do you think? If you're if I were to spell it correctly, if you were the examiner and you saw that the addition of the word preferred, is there any increased chance that you would tend to say, well, why was it preferred? What are the other, preferred to what? In what way? Pros and cons. What do you say?
Why was it preferred?
Yeah, well, that's basically saying, why was it preferred? Which actually, that's the exact question you want, correct?
Yes.
So are you comfortable with that one?
I like that a lot. Yeah.
Excellent, good. You see how just the addition or subtraction of a word or two or three can make a huge difference. It really can. Okay, next question you wanted to, the pros and cons of a concomitant sling. Now, can you be a little bit more specific? Where do you want to go with this?
So there's kind of two lines of thought that you can kind of correct the prolapse.
Can I interrupt you for a second?
Yeah.
Sorry, are you an FPMRS by any chance?
Yes.
Okay, minor retraction. We still do exactly this, but the only difference is the examiner in very short order will realize that you're an FPMRS. Now, for that reason, they would expect you to know the answer to FPMRS type questions. So the ability to entice them to ask the kind of questions is reduced slightly. It's not as effective as if you were a generalist. Do you understand? Because the examiner will expect you. So I will just share with you that for Lindsay, are you a subspecialist as well by any chance? Not. So it's better in this instance for what we're doing. For you, actually, anything that's general OBGYN, those are the things that we want to harp on big time. Okay. So if this person had, for example, a blood transfusion or a post-op fever, I would try and hone in on that. But that doesn't mean to say we shouldn't hone in on what you've done. Okay. All right, getting back to what you said, tell me where you want to go with pros and cons of concomitant sling therapy.
I mean, some people
Treatment.
would talk about how doing them both at the same time reduces your need for a second operation. And then there's also the line of thought that kind of correcting the prolapse, about 40% of them don't actually need a sling. So I think talking about those differences and why I chose to do one would be a good question.
So maybe we can get that into the conversation by writing down on paper declined concomitant sling procedure. What do you think?
Yeah, I like that.
You'd be okay with that? So cystoscopy, and then at the bottom here, I'm going to write declined, concomitant. I don't even know how you spell concomitant. Is that correct?
I think there's an N in there.
Concomitant. No, it's commitment. No, concomitant. No, that's what it is. Maybe concomitant. Lindsay, you're very quiet. Help us out here. You're muted.
Yeah. No,
I think I've got it right now. Anyway, these are minor they're actually for your final cases. You need to sort this out, but I think I've got it right now. It's not highlighting it as a words, not highlighting it as a spell check. So decline concomitants, sling what were we going to say? Ashley,
Decline concomitant incontinence procedure.
Incontinence procedure. Yeah, I like that because it really begs the question why, and that comes to how did you counsel her, which I think is where you want to go with this. Am I right?
Yes.
Perfect. Okay, so we've got the third one. Next one. Management of failed voiding trial. Are there any specific aspects of that you would like to accomplish?
How you perform a voiding trial, what you typically do, like after she's failed, do you send her home with the Foley, with or without antibiotics?
Look, first of all, most people would have written down voiding trial. And my recommendation, you've beat me to it, my recommendation would have been add the word failed, because that already increases the likelihood of all these questions coming up. If we can either leave it as is, or we can add failed voiding trial with ongoing treatment, or something of that nature. What do you think? It's up to you. What do you think?
I like the with ongoing treatment.
Okay, so let me just change that. All right, now, what I want to do is I also want to encourage you, and I know I'm going a little bit against the very short list of abbreviations, but in this section here, the treatment, it's a very long section. You want to make your cases as easy to read and as word poor as possible. So I'm going to see how this looks. If I change it to supracervix. No, sorry. No, that doesn't look good. Maybe we should change it to supracervical. I'm trying to get it to save a line. There we go. Supracervical history. Why don't we change bilateral salpingo-oophorectomy to BSNO? That's very commonly seen on case lists. Are you comfortable with that?
Yes.
Okay. So BS. I'm just trying to neaten it up now. That's all. I'm going to have to shut this cat up very quickly. Excuse me, folks. I just want to finish this. Okay. Then the sacrocolpopexy is correct, preferred. Sacro. Well, no, that won't fit in. Periodorophy. Let's take up cystoscopy. The word, no, we won't get cystoscopy on the same line, so leave it there. Declined incontinence procedure. How about that? Are you comfortable with that, Ashley?
Yes.
Okay. So we haven't made any major changes here. They're really subtle changes, but I think we've increased dramatically the chances of the desired questions coming up. Would you agree on that, Ashley?
Yes.
Lindsay, how about you? Would you agree on that?
I mean, you're saying that if it's very if there's a lot of words, they don't like it. They don't like.
No, reducing the words. The thing I did at the very end was with a completely different aim in mind, and I'm bringing in another exam technique issue. Part of being a good candidate is answering effectively and producing a good case list. If you can say something in 5 words, don't say it in 6, because your examiner has to read it, and the more they have to read, even if they just look at a page full of words, it's very exhausting. You want the examiner to be able to look at your cases, get a gist of what's going on quickly and easily, because the corollary of that is they would be ticked off that you're giving them, you're having them work so hard to understand what your case is all about. And it's that latter thing that I'm trying to avoid, just as a general principle. It's got nothing to do with increasing the likelihood of particular questions being asked. Okay, so with that in mind, Lindsay, be honest, do you feel this is an improvement?
I mean, I guess so. I really don't see the difference that much. I mean, BSO and Abdo, I guess, but
No. I'm not talking now about making it neat and short words. That's not what I'm referring to now. I'm asking, do you think the way we added some words and changed the phraseology, that's what I'm referring to when I asked the question.
I think that's better. Yes.
Yes. Okay, that's what I meant. Okay, Ashley, are you okay with that?
Yeah, I like that.
Okay, good. So what I'm going to do now, I'm just going to get rid of this cat in this room. I'm going to turn the air conditioning on as well. Forgive me, I'll be 1 second, and then we'll start up again. Lindsay, we'll take your first case. So hold on 1 sec. Okay.
Just gonna switch to the computer if you don't mind letting me in.
You want to let you want me to let you in? Yeah. Hold. I see that you've come in again. There we go. Admit. There we go. Okay. You can keep yourself on twice or knock yourself off the on the what's his name. Okay. All righty. Let me get Lindsay. Let me get yours. Here we go. Lindsay, should we start with the first case?
Okay.
Okay, so let's just read it together. In the G1 section, 48-year-old gravida 0, para 0, 20-week fibroid uterus, abnormal uterine bleeding, failed to respond to medical therapy, chronic abdominal pain, heaviness, previous myomectomy 20 years ago. So she had a myomectomy at age 28, para 0, I guess part of an infertility scenario. Complicated by large blood loss from DIC. You did a supracervical again, okay, bilateral salpingectomy. Uterus rate 2200, fibrous ischemic degenerative hyalinization, dystrophic calcification, mid-secretion bilateral fallopian tube. Okay, this is why you want the case, the complication, correct? This is your big issue on this case.
She's a history of bleeding.
Okay, so let me see. Midline incision, attempted to not have incision above umbilicus, but it was too big. EBL 1500, pre-op 13, intra-op 10, post-op 7.5, discharge post-op 10. Okay, so look, it's an interesting case. It's a great case. You should just know the cases that are most problematic and worrisome to candidates, as a general rule, I love the most, because you can prepare so easily for those cases. Okay, so Lindsay, what I'm going to do with you here is exactly what I did with Ashley. Let's start by asking, besides the complication, are there any other concerns that you've got?
No, she did well afterwards.
Okay. What are the questions? What are the discussions that you would like to have? What kind of conversation would you like to have with your examiner on this case?
Sorry, I'm not so sure, to be honest.
Okay, so let me throw up to you folks where this case is going, and I want you to tell me which of the questions that I'm going to raise, because I'm going to give you a whole battery of questions that any reasonable examiner would ask based on what's down here. And then I want you to tell me which ones appeal most to you, and we're going to focus in on those, okay? So the first one is the prior history of blood loss and DIC. and how did that affect your management in this current presentation? What was the failed medical therapy?
Mhm.
We can get into a discussion on hyperplasia and adenocarcinoma. Same thing as I mentioned before. It's a favorite, by the way, supracervix versus total hysterectomy. Okay. I tend to think at age 48, they're not going to get involved in a conversation of bilateral oophorectomy. It's too young. 20 years ago, they would have invited that, but not now. You've got a weight of 2,200 grams. That begs the question, did you consider Depo-Lupron therapy preoperatively? That's a question you can have. You listed 1, 2, 2.5 kinds of degeneration. Do you want to list the different degenerations that a fibroid can undergo? Okay. Now, with respect to the complication, pros and cons, and I like this one. I hope you're going to say you want to go for this. You may not. Pros and cons of different entries into abdomen. So we're talking abdominal entries. I'm just writing this down. Entries. We're talking about Maillard versus Phanestoel primarily, but they can also ask you about Phanestoel, Maillard, and midline infraumbilical. So your choice of incisions, discuss the EBL. Why did it occur and what did you do? And the third thing is conditions to prerequisites or conditions to reopen the patient. It didn't happen in this case, but when might you have considered that? Okay, so I've given you 1, 2, 3, 4, 9 potential conversations there. Choose, let's say, 4 which you would really love to have. If these 4 came up, you would do very well on this case.
I mean, I guess the way that I presented the case, it'd be like talking about blood loss, symptomatic.
Okay, I forgot to mention blood loss also means blood transfusion and blood component therapy.
Right.
Is that one you want to have?
Yeah, I guess so.
Okay, give me one more.
And also the entry.
Okay, it's a great discussion point. Okay, what else?
You were saying like I had to discuss why there was blood loss. Because of the degeneration of the fibroids is when we grabbed onto the fibroids to lift it, it just was like mush, and so every time we tried to grab it to pull, it just started bleeding more.
Okay, so that's a simple answer. There's not much. The answer to that is get on with the hysterectomy, correct?
Yeah, just finish the hysterectomy. Yeah.
Yeah. There's one more question that I didn't ask you, and it's very likely, and you may not be ready to answer it now, but I would encourage you regardless, and this is to both of you and everyone else who's subsequently going to be listening in. I encourage all of you to be comfortable to handle a question on the course of the ureter. And why, Lindsay, it's a big deal for you because you've got a big abdomen, a big uterus. And you can easily, especially when you've got excessive bleeding, you can put a clamp on a ureter. So I want to add that to the list of possible questions. Do you want to choose that as a question that you would like to get in the exam, or are you just totally not comfortable with that?
Well, I'm still in the beginning stages.
Okay.
But I think it's a good. I think it's a good question.
Okay. So are you comfortable at this point
At
But
this
by the
point,
time, but by the time you walk into the exam, you will be okay with that question.
yes.
Okay, so then I'm going to include that as well. All right. Choose one more topic. Do you want me to call them out to you, or you got them written down in front of you?
No, I mean, I didn't really.
Okay,
Yeah,
I'll just if there's anything
read it
else
out
that
to me.
okay, if there's anything else that grabs you, given the prior history of DRC, did you do anything differently in preparation this time around? Failed medical treatment for AUB, hyperplasia and adenocarcinoma. That's unlikely because she's 48. In fact, there's something here that I missed. There's no mention of use sampling the endometrium preoperatively.
Oh, yes, I should write that. Yeah.
That must go down. Okay. I'm
Okay.
assuming you did that, correct?
Yes.
Okay. So once that in fact, I'm just going to add it right now. Okay. Because I don't want you to leave that out. What would this be? Endometrial office biopsy?
Yes.
Okay. EB benign. That's all you need to do. Okay. So now that issue, we don't have to, they're not going to ask, not in a 48-year-old. Okay. What about supracervical versus total? Pros and cons. When would you do it? Emergency versus elective conditions. Would you want that conversation?
Oh, I guess it's a good conversation.
Well, I'm guessing that's why you did a supracervical in the end. Am I correct? Or was this planned as a supracervical
It
from
was
the
planned
beginning?
as a It was planned as a super cervical.
Why?
It just it's an easier procedure, less likely for, for
Okay,
prolapse later on.
I'm going to for you add that as your fourth option. Okay, because I think it's a favorite type of question in the exam. Okay, so let's go through the four things. It's supracervical versus total. It's discussion of the ureter and pros and cons of different abdominal entries, and the EBL and blood transfusion. How did you manage that? Okay, so let's look at supracervical versus total. Tell me again, we want to get this conversation going. You planned this as a supracervical because why?
I mean,
Don't be
lots of
shy.
things.
Don't be shy. I'm not. Don't get me wrong. I'm not. The tone of voice should not come across as accusatory. I'm just want to get it clear.
I mean, we presented both to the patient, explained risks. I think she was concerned about postoperative sexual pleasure, and which is not, not proven, but that's what she was saying. So we were saying, okay, we can
Okay,
treat the cervix for that reason.
so there's a bigger conversation that you can have, but for the present now, I want to go over how are we going to get that conversation. Once we've worked it out on paper, then at a subsequent time we can go over and review the specific questions that conversation is going to entail. But right now, I would write supracervical hysterectomy. I'm trying to think here.
Patient preference.
You can patient preference. Ashley, feel free, obviously, to chime in here. I'm just thinking supracervical history. What about TAH considered suboptimal or suboptimal? What do you think about that, Lindsay? Don't be shy. You can say you don't like it. What do you think?
I'm not sure if I like that, but
what part don't you like? The word suboptimal or the whole consideration?
no, the suboptimal.
Okay.
I mean, it could be like, why was it suboptimal? I mean, I guess
That's exactly the question I want. You understand?
Yeah.
The fact that you say it's suboptimal means that what you did was optimal, and it begs an explanation. Ashley, let me ask you your opinion. You've heard Lindsay and my back and forth on this. What do you think? Feel free to disagree with me and take Lindsay's side. What do you think?
It's honestly something I wish we had done on mine, saying the, total abdominal is suboptimal, because that you explain why your option is better.
Yeah, so you can change it. We can change yours as well. It's not fixed in stone, obviously, okay? But in this case, which do you think is it likely to generate the question, the conversation that we want to have? Ashley, what do you think?
Yeah, I think talking and saying the word suboptimal really begs that question, and it's not like accusatory either way. It's just in this case, I did what was optimal.
Yeah, that's
because
right.
this other option was-
By contrast, I didn't do that. I did this. Lindsay, I don't want to pressurize you, but do you feel that maybe you want to reconsider this, or do you still not like the? Because we can
No,
come up
it's
with
fine.
other
Let's do it.
options. You okay?
I think
Okay.
that sounds fine. We could put that in there.
Okay, TAH suboptimal. The examiner reads that, he or she is almost forced to ask you why. Okay, so that'll get that. Just that one word, 2 words will get that conversation going. Now, pros and cons of the various abdominal entries. What I want to write here, I don't want to use the word suboptimal twice, okay? But if I didn't have it for the supracervical aspect, I would have recommended Pfannenstiel suboptimal, okay? You did a midline infraumbilical, yes?
Yes, we tried.
Would
Mhm.
you be comfortable to you said you didn't want to go was it in this case you didn't want to go above? No, that
I
was
mean,
the previous.
no,
Yeah, you
this
didn't
one
want to go
says
above the umbilicus. Yeah.
Mhm.
What? So if that was your concern, in retrospect, with hindsight, should you not have considered a Maillard incision, which is a muscle cutting incision of the rectus and gives you more exposure, supposedly?
Yeah, I was just considering that we should just like instead of trying to be aesthetically pleasing, just done the incision the way that we needed.
Okay. Okay,
Yeah.
that's fine. That's fine. So you can write the midline incision. You can, if you want to get the conversation going, you can add in parenthesis Pfannenstiel and Maillard discussed, or Pfannenstiel and Maillard considered. How about
Mhm.
that?
Okay.
Which word would you prefer?
Discussed.
Okay. Maillard and Pfannenstiel, I think. Discussed. I think that's correct, yeah? Are you okay with that? Ashley, what do you think about that option? Would it increase the probability of the examiner seeking clarification and getting that conversation going?
Yes.
Good. Okay, we've got 2 down, 2 to go. Lindsay, you want to talk about blood component therapy, correct? Okay.
Yeah.
You, based on what you wrote here, you didn't give her a blood transfusion, correct? Or you did? Because you didn't
No,
mention
I
it.
don't. I don't think we did. I have to.
Okay. Okay. I'm inclined to write a couple of options here. No transfusion given, which is most in your face. You could say no transfusion required, but I think no transfusion given, because it leaves, you won't like this, okay? It leaves a doubt in the examiner's mind when you say given. Was that out of your choice, or did someone slip up and it should have been given? I like to entice the examiner to think, wow, they start thinking they've got their teeth in the meat and they've got you, but actually they haven't. But it's a question of how comfortable you are. So which would you prefer there?
I mean,
Or
it's like-
avoid, you can say avoid it also. You can use any word you want. Transfusion. Sorry, what do you want? Not given, avoided, held off. I don't know. I'm thinking aloud. Help me out.
I mean, you can write not given.
Would you be okay with that? I think it's. I think
don't
it's.
know yet.
No. Are you not comfortable? I don't want you to have me write something down just for the sake of saying it. Are you not comfortable with that?
Well,
Well,
I
let's
think so.
say,
Now you're making me like I have to question myself. I have to go back to the case you gave it.
okay. What about not
Yeah.
required? How about that? Not required.
Okay.
Would that be a little softer?
Okay. Sure.
But listen, Lindsay, if any recommendation that I'm giving you now, you're not comfortable with it, I think what I'm hoping you and everyone who's watching and listening in will realize, just think about it and work out what words convey your sentiment and are most likely to generate those questions that you're looking for. So okay, and I would leave those hemoglobins in there. That's fine. I don't mind. And so that's okay to try and get the blood component therapy discussion going. Okay, Ashley, you're okay with that?
Yes.
Okay. Now we want to talk about ureter. What about coming in here and adding
You
that?
say
Just by the way, can I make a suggestion? What I encourage you folks to do is to do bullet lists. It makes it much easier for the examiner to follow.
Mhm.
Oops, sorry, that's in the wrong area. Why is that? I don't know why it's coming on the. Let me try this. I don't. Oh, there we go. Okay, sorry about that. And now, we can do simply concern for ureteric injury.
Okay.
You okay with that?
Yeah.
Now, when you write concern for ureteric injury, the kind of questions they will ask you.
I mean, doesn't that imply that like I was like, why didn't you do we didn't do a cystectomy, like we palpated the ureters. So we prior to clamping. So like, you know, because if they did you're concerned, why didn't you call in urology? Why didn't you do a cystoscopy?
No. Or okay, why don't you write heightened awareness for ureter location? How about that? Whichever, it's up to you. Which do you prefer? Increased awareness for ureteric location. Would you prefer that?
I guess so.
No. It's again, Lindsay.
I mean, I don't know.
Okay, Ashley, your opinion. Which do you think would be better?
I think increased awareness adds like, okay, why were you increased aware?
Okay.
Versus concern is like, why didn't you do the cysto? So
Okay,
increased
fine.
awareness.
Okay, increased awareness for ureteric anatomy or location?
I guess location.
Oops, sorry. And by the way, you did do a supracervical here, so that fits nicely with this issue. So you put that in, and now you get the conversation of ureteric anatomy, ureteric injuries. Where do they occur? They can even ask you if you're going for the gold prize. How do you repair a ureteric injury? This kind of thing. Okay. But I think the chances of being asked these questions have gone up dramatically. Now, I just want to shorten where I can. 20-week size fibroid uterus. The word size can come out, correct? This is just to make it look good and make it easy for the examiner. AUB, failed medical. I always like to, again, I've been doing this for over 20 years. I've never heard of anyone who's run into a problem. Management changed to treatment and chronic LAP. Oh, you got heaviness. Maybe I'm changing it into something that it's not. Which would you prefer, Lindsay?
I think it's okay.
Okay, so it's up to you. I don't feel obligated again. Chronic LAP?
Okay.
Okay. You don't sound over enthusiastic. You're describing more a space occupying lesion, pressure, chronic pelvic pressure. What about that?
Okay, that works.
Okay. Or just pelvic pressure, because it's not, pelvic pressure is never acute when you think about it. Oopsie, excuse my spelling. Pelvic. Okay. EB benign prime myomectomy, 20 years. Now, do you want to have a conversation on the previous DIC and blood loss, or would you rather just leave it out?
Originally I thought that would be a good conversation, but
I think the 4 that we chose are far better conversations for the exam.
okay.
Ashley, what do you think? The 4 that we chose. And again, be comfortable to disagree with me. Ashley, what do you think?
I think, if you took the large blood loss previously in the DIC into great consideration and you did, preparations for it, it might be a good question because you have something on hand. But if you just know about this history and you didn't do anything, it might not be a good question.
Valid point. So Lindsay, I come back to you and say, would it suit you to have a conversation on how you prepared this patient preoperatively any differently as a consequence of this history? Actually, that's what you're getting at, yes? Okay, so Lindsay, would you like to have that conversation or not? Or is it not important to you?
I mean, we can delete it. We did prepare for it because of that history, but
it's up to you. I'm just saying, if you want,
know.
okay, I will leave you to leave it in or take it out. But if you want, oopsie, sorry. You can just delete all that. Okay.
Yeah, okay.
But I'll leave it in. This is good. Increased word for ureteric. Sorry, increased with. We wanted to say increased concern. No, we wanted to increase awareness of ureteric. This is what I want to take out. Yeah. So supracervical hysterectomy. It says suboptimal, and again, I would write here BS. Okay, and take this out. Okay, and supracervical should be a capital S. Just being picky now, forgive me. Uterine, yeah, every word is unnecessary. If we've got a number next to the uterus, it's the weight. We don't need to say weight, okay? Leiomyoma, okay, that's fine. Mid-secretory. Yeah. I would just say benign endometrium. That's all that's important, okay? Because you don't want to get a question, well, what's the difference in histology between secretory and proliferative endometrium, okay?
Oh yes, don't.
None of us like to get histology if we can avoid it. So endometrium get this through. This is not trying to predict the questions now. We're just making it clean, okay? The endometrium benign and fallopian tubes, not that they were benign. You've got to say what they were. Oops. Okay, midline incident, male on discussed, attempted to. I think
Attendance,
this should come out.
umbilical.
Say again? No,
Oh.
I'm saying this is going to come in because when we get
The
the
discussion.
conversation of Maillard and Vance, you'll bring that in verbally. It's much better
Oh.
to speak it than to read what's on paper already.
Oh, okay.
Does that make sense to you?
Yes.
Okay. So let me just again make this, sorry. I encourage all of you folks, do it with the bullet list. It's easier to read. Okay. We don't have to say discharge post-op day 2 because it says there in the next column, went home 2 days. So I'm taking that out, okay? All right. All right. How does that sit with you, Lindsay? Please, it's really important. You have to be internally comfortable with it. If not now, you've got to be comfortable that you will be comfortable by the time you walk into the exam. But I don't want you to say, yes, it's okay when you really are not comfortable with it, because that defeats what we're trying to do here. So your honest opinion as it appears now, are you comfortable with the way it appears? Are you comfortable with the kind of questions that it's going to generate for you?
I think so.
Okay. Ashley, you as the eyes and ears of everyone else and the potential examiner, do you feel that this would increase significantly the likelihood of getting the questions that Lindsay wants?
I think so, yeah.
Okay, good. All right, let's go back. Let's switch roles. Thank you very much, Lindsay. Ashley, let me find your case list. Here it is. Okay, you want to go to the next one or you want to skip?
Can we skip and go to my obstetrical one?
This one?
Yes.
Okay, let's read it together. 26-year-old gravida 6 para 5, 38 weeks, 5 days. History of prior C-section. Now, is it ×1 or times, because she's a para 5? What's how many C-sections?
Just one.
My inclination is to put that down on paper. I'm going to do that, okay? History of preeclampsia, insufficient PNC, homelessness, homeless. Okay, good enough?
Yes.
Okay. Primary PPH, EBL 1015, uterine atony, trial of labor. No, so okay. I'm doing a little bit of here. I'm going into what I discussed in other lectures, but it's really relevant here. Philosophically, if you're doing a TOLAC as opposed to a repeat C-section, it speaks volumes to your philosophical nature as a conservative OB. Would you agree?
Yes.
So for that reason, we want to promote TOLAC left, right, and center as much as we can. If the examiner were to just very quickly glance through this, he or she would just see words. But if you had the abbreviation TOLAC, that's a subconscious recognizable word, which is actually an abbreviation. And so I want, wherever possible, I want you to put down the word TOLAC. So I'm going to change that right now. Does that make sense to you?
Yes.
You see, TOLAC, it's all capital letters. It stands out. The examiner is more likely, when he or she screens through it, to recognize, and it speaks to your advantage. It speaks to conservatism. Okay, so this is not, it's not such an interesting case. At the end of the day, it's a mild PPH. For an FPMRS, this was probably horrendous, but it's not a. It's I'm being mean spirited. I'm sorry, but it's not a major PPH. I'm guessing you nevertheless want to have a PPH conversation here, correct?
I would be comfortable having a PPH conversation, but
Is
after this now.
correct? Okay. And just by the way, I'll get a plug in. Look, we know historically that people that engage us for the cases construction aspect, they come and follow up with us, virtually every one of them, to our definitive board prep course. And you should know, at our definitive board prep course, this is such an important subject. It's the number one most commonly asked question in any OBGYN board exam. You've got to know it cold. We'll spend about an hour and a half just on this. So we've got you covered. I'm not worried that you'll know the stuff before you walk in. So you coming back to here, and now you want to have a conversation on postpartum hemorrhage, correct?
Right.
Any other conversations you want to have?
How would you counsel a patient on Tolac? What are the uterotonics that you would give? I don't really even know if I need to include the homelessness and insufficient prenatal care, or if that's something
well, I will tell you, it is a conversation piece, and the reason why I say that is about 8 years ago or so, there was a committee opinion which included issues relating to homelessness and pregnancy. So I would ask you, if you want to keep that, you don't have to. It's one of those things that's optional. But if you keep it in, and that's fine, just make sure you've just check up that committee opinion. It's several years ago, okay? I can't recall the title, but I think the word homelessness or homeless is in the title, okay? Okay, so you want to have a PPH and a TOLAC conversation. That's what you want to get out of this case, yes?
Yes.
Okay. What was the patient's position, if any, given the fact that she had insufficient prenatal care? What was her position regarding TOLAC?
She came in 6 centimeters. And
okay. Okay, so that makes it very easy. History C-section ×1. I'm going to put this TOLAC counseling in the delivery column, because that's really when it occurred. Am I right?
Right.
Cut. Let me just neaten this up quickly. Sorry.
Would you write VBAC there for the other one?
Say once again, sorry.
For the procedure, would it be VBAC?
Well, I'm going to get to that. You're quite correct. Yes, it becomes, you see, you want the words TOLAC and VBAC to appear as many times as you possibly can. And if you can get them to appear twice on one patient, go for it. Okay. So what I would put here is VBAC, as Lindsay said. Okay, and uterotonics. Okay, now, Lindsay, you may not like this. Sorry, Ashley, you may not like this, but I'm going to encourage you to write TOLAC counseling in labor with 3 exclamation marks afterwards. You understand why? Because how often does this happen? Okay, so let's just see what it looks like in labor. So where am I? I'm in labor. And now I must get a new line because I want those exclamation marks to stand out. I'm even going to do that, okay, to make them stand out. Now, Ashley, or let me ask you, Lindsay, what do you think? You're the examiner. You see that TOLAC counseling in labor with 3 exclamation marks. Are you moved to ask any questions as a consequence of that?
I mean, you said that she didn't have any prenatal care and she was homeless, so it makes sense that you just have in labor. I might say like, why are there 3 exclamation points? And
Oh,
then
no,
say
the
she
examiner would
didn't-
never say that. Okay. Because, and you can
I don't
always
know.
answer because it was so unusual. That's easy. What about this? You can say typical TOLAC counseling, not possible, not feasible. What about that, Ashley? Would you be more comfortable with that?
I actually like that a lot. Yeah.
Lindsay, what about you? How does that
Okay.
seem to you?
Yeah.
Okay. So standard, or do you want typical TOLAC? Sorry, TOLAC counseling, not feasible, not possible, not feasible. What do you want?
Not feasible.
I think I've spelled that correctly. Do you want the exclamation marks or not?
Maybe no.
Yeah, I've yet to come across a candidate who's okay with that. Not even one. I'll get rid of it. Okay. Are you comfortable with that now, Ashley?
Yes.
Okay. And then we just need to put make it a bullet list like that. Okay. I think this is good now because you see TOLAC VBAC in the case. You've just increased dramatically the probability of being asked about selection, counseling, etc. And because you've got standard TOLAC counseling not feasible, you've just increased that aspect of the conversation much more. Ashley, are you comfortable with that?
Yes.
Lindsay, what do you think? If you were the examiner, would you be more inclined to ask a little bit more about this?
I mean, you guys like, what is standard TOLAC counseling?
Yeah, that's the question we want. What is your typical counseling? Yeah.
Mhm.
Okay, good. You don't sound over enthusiastic, Lindsay.
I just don't know what to expect. Sorry.
Okay, that's totally fine. But when I pose these questions to you, I don't want you to put yourself in the candidate's position. I want you to pretend you're an examiner. And if a
Okay.
candidate showed you this on their cases, what would you as an examiner say? Okay. All right. But Ashley, you're okay with that?
Yes.
Okay. Now we want to get the PPH going. Yes.
Yes.
Now, let me have Lindsay answer this question. Lindsay, what do you think, how much blood loss do you need for EBL for a PPH to be regarded as, okay, this is now significant? What would you say? Ballpark.
You call PPH at 1,000.
No, but when does it become a major PPH, not just a run-of-the-mill PPH?
Oh,
At a
is it
blood loss
true?
of about what?
It's 1,500.
Yeah, I would say
2,000.
15 to 16, maybe 1,800, thereabouts. But 1,000 cc's doesn't impress me. Okay. So because you only had such a itty bitty little PPH, I want to recommend we take the volume off.
Okay.
Let the examiner think it was 1,500 cc's. Okay. And the message I would give to everyone listening in, if you've got a PPH on your case list and it's less than about 1,500 cc's, then leave the EBL off. It doesn't help. It's a minor PPH. But if it's more than 1,500 cc's, then yes, put the EBL down on paper. Does that make sense to you?
Yeah, that's fair.
Okay. So number one, we take that off. QBL, forgive me, the Q is?
Quantitative.
Oh, okay. So I'm going to take that off as well, yeah?
Yeah.
Yes, you okay with that?
Yes.
I'm old school. I talk of EBL. Okay, now we want to try and get a PPH discussion going. This is a major question in the exam. I've always encouraged candidates to do the following, and I'm going to say the same thing to you, Lindsay. Did you attempt bimanual compression, uterine massage? Okay, what is
Yes.
that? That's what I call mechanical PPH management. Okay, just getting your hands in there, and if any bleeding, tears in the vagina or cervix, you'll suture up. Again, it's mechanical. Then you gave uterotonics. That's pharmacological. So I'm throwing it out to both of you. I would encourage you to write, instead of uterotonics, I would encourage you to write mechanical PPH management, and on the next line, pharmacological PPH management. Okay. I see Lindsay's nodding her head in agreement. You like that, Lindsay?
Yes, because then they'll ask you.
Yeah. What do you mean by that? What does it mean?
You
Yeah.
have to answer.
So Ashley, what do you think about that?
I think that's great. And it expands that area.
You're expanding the conversation in an area of your strength. That's exactly what we're trying to do with this exercise today. Exactly right. So I'm going to just change this to mechanical PPH management. Did I spell that correctly? Yeah. Oh, no. In fact, you know what I'll do? Because I want to reduce the words. Sorry. Make it easy and quick for the examiner to read. And then the next one is pharmacological PPH. Oh, geez, I really want to get that. Pharmacologic. There, that gets it there. How about that? You see, I'm trying to get it clean and neat. Ashley, would you be comfortable with this?
Yes.
And Lindsay, you're nodding your head. You agree this would increase the likelihood of getting the questions that Ashley's looking for? Success. Okay.
Yes.
All right. Ashley, are you sure you're comfortable? You've got a look on your face of doubt. No, please.
No, I'm comfortable with it.
Okay, great. All right, good. Let's switch over now. Lindsay, we'll come back to you. Okay, which case would you like to go through?
We can do an obstetrics case.
Which one would you prefer?
I mean, either, it's fine.
Okay, let's do the first one, number 86. Okay, so let's go through this again together. 31-year-old, Bravida 2, Para 1, 37 weeks and 6 days. She has gestational hypertension, oligohydramnios 4.3, no 2x2 pockets, diabetes class A1. She ruptured more than 24 hours. Sorry, ruptured membranes, not uterus. Okay.
Not uterus, yeah.
Yeah, okay. GBS negative, no fever, no antibiotics. Let me just see. Okay. Category 2 tracing Pitocin, stop patient refuse and refuse C-section, amnio infusion. Oh my goodness, improved. So
Sorry.
no, these are the juicy cases. These are wonderful. You'd be thrilled about this. Don't apologize. Stage post vacuum, retained placenta, DNC, PPH, JADA placement, vacuum, boy, OA, either.
I wrote too much information.
Correct. And the first thing I want to do is I want to
just leave it as oligohydramnios, and then I have to explain it.
That's right. Reduce the words. Would you be comfortable to walk into the exam if all you saw was oligohydramnios, that you could add verbally the 4.3 and the no 2x2 pocket? Would you be able to remember that?
I feel like I wouldn't remember.
No. So if you needed to trigger your memory, then we need to consider leaving it in. So it's up to
Okay.
you. Would you like to
Yeah.
leave it in?
I guess I leave it in.
Okay.
fine.
Okay, so then, but all I'm going to do is I'm going to put this in parenthesis. Okay, smiley. Okay, and again, it's just so much easier to follow if you
Mhm.
do this. Okay,
And
I
that's
think we
also
need to say
like, you just
ROM.
like you go SROM more than 24 hours.
Yeah, this is to be ROM, not rupture. SROM. Okay. Okay, and each one on a new line, it's easier to read.
Mhm.
Okay, we can leave GBS in negative. We'll come back to that.
It's like no choreo.
Um,
I don't know.
no, I like that. I'm trying to work out what's the best way. You want to get a choreo conversation going, yeah?
Yeah.
Yeah. What about rule out choreo?
Okay.
You okay with that? I mean, you have to say yes. No, yes.
Yeah, that's fine.
Okay. Rule
Ruled out choreo.
out choreo. And then the rest
And
can
delete
come,
that. Yeah, the rest can come out.
out. Do you want the amnionitis in as well or no? Up to you.
No, I mean, I
Okay.
think it's up. What do you think?
Okay. I think it's okay. It's fine.
Mhm.
Okay, rule out. That's good. Okay, category 2 tracing. Let me just see what we got here.
I want to emphasize like it's a prolonged labor course because we had to stop the Pitocin.
You
and facius
do
decline.
or you don't want to emphasize the prolonged course.
I mean, that's what
I
was
just didn't hear
saying.
you correctly. What do you want to
No,
do?
no, that's what I think by Pitocin stopped. That's what I was thinking when I wrote that, but I guess it's not really
Okay,
necessary.
do you want to write category 2 fetal heart rate tracing? Okay, let's leave Pitocin stopped for the moment. Okay. We don't say the patient refused because she's the only one that can
Declined.
refuse. No, refused C-section. This has to be in capital letters. C-section. Sorry, we want to emphasize this.
Mhm.
I'm doing it on my copy. If you can't do it in the on the software, I'll just show you what it looks like. I'm not sure you can do this on the software. If I make it bold, you see how it emphasizes. That's a big statement to emphasize, yes?
Yeah, but
So
I don't think you could.
I don't think you can do that. Underline, I don't think you can do either.
No.
Okay, it has the same kind of effect.
I think caps locks you can.
Caps you can do. That's exactly right. I think caps is the only thing you can do. So let's do refused all in caps. Okay.
Mhm.
You know, I would love to put an exclamation mark there, but you'd rather not, yes?
I don't think so.
Okay, all right. Okay, then amnio infusion. So, let me get this here. This needs to be on a new line. There we go.
Mhm.
And so amnio infusion and Pitocin restarted. Yeah? We're saying the same thing, but in fewer words.
Okay.
You okay with that?
Mhm.
So then then she delivered a vacuum. She had a vacuum delivery. Yeah?
Right.
We can't go to status post. Vacuum vaginal, retained placenta, DNC, PPH. I'm not, forgive my ignorance. The trade name JADA is what?
It's a new device that's on the market that does suction. There's a suction device inside the uterus to cause uterine contraction. to
Oh,
prevent
so it's primarily to create a negative pressure to
negative pressure.
assist in retraction of the uterus.
Yes,
Okay, fine. So are you comfortable to talk about that?
yes.
Perfect, perfect. So procedure, vacuum vaginal delivery. I don't care if it's a boy or a girl or anything else these days. It can be a few other things as well. OA, if it was a OP position, I might leave the in, but OA is the normal. It's the easiest. It doesn't add anything, so I'm taking it out.
Okay.
EBL 350 cc's is not by definition a PPH.
Oh, I wrote initial EBL at the delivery was that, but then I was like, then she started bleeding afterwards. I don't know. I should have deleted. I don't know. I
tell
wrote that.
yeah, I'm just taking it out. Just leave it like that, okay?
Okay.
And clots.
We had 2 times we had to express it, and then we did a sono, and we're like,
Okay,
because like,
I want to make the following. We've already mentioned postpartum hemorrhage in the delivery column. Okay.
oh, okay.
So why don't we do the same thing what we mentioned with Ashley? Mechanical PPH
Yeah.
management. Okay.
Mechanical and
Yeah.
pharmacological.
Mechanical PPH therapy.
Alright.
Okay. And then did you do pharmacological as well?
Yes.
PPH. Now, you also did what is it, Jada? How do you pronounce it?
Jada.
Okay. What about doing this? Surgical
Management.
PPH management. How
That's
about that?
better.
And I would take the Jada placement off here. What do you think? Okay. Are you okay with that?
For procedure, yeah.
Yeah. Because it's going to be inferred here. So clots express that we've already covered that.
Covered that, yeah. Surgical is the DNC.
Surgery is DNC. We can take that out, and JADA we can take out.
I mean, we have to put the Jada somewhere, either there or
Okay. Surgical PPH here. If you want to put it, how about this? Including
Jada.
Jada. How about that?
Yeah, that's fine. And you can delete the rest of it.
And the ultrasound guidance, I think, can come out.
Yeah.
There's nothing that you can't say verbally. I think, sorry, this needs to, all this comes out, yeah?
Yeah. Okay.
I think that's a lot neater.
Right.
You okay with that, Lindsay? Yes?
Yes.
Okay. Ashley, your opinion. Again, be honest. Do you think the changes that we've made are likely to induce the kind of questions that Lindsay's looking for? And you can disagree. Please feel free.
No, I do. I think so.
Excellent. Excellent. Look, we've done 2 cases each so far. Let me just pause here for a moment and ask Ashley, let me ask you first. The thing that we're doing, does this make sense to you? Or do you think we're just, we're chancing our luck and this is really not real? Please be honest. Do you think this is really going to make a difference?
I think it's really going to make a difference. I think kind of expanding what we want to talk about and shortening elsewhere really helps kind of highlight those areas.
That's exactly right. You expand what you want to talk about, you minimize that which you don't want to talk about. Quite correct. And Lindsay, how about you? Does this make sense to you, what we're doing?
Yeah, when I originally was like making the list, I was just like transcribing, like, oh, I just did this case, I'm gonna put it on the list, and I wasn't really thinking about how I wanted to be read.
I'm pleased you mentioned that, Lindsay, because at the end of the day, when your case list represents 50% of your exam, and you've got it in your hands, in your lap right now, you can construct it in such a way to set you up for success or failure. And because the stakes are so high, if you come to our courses, you'll hear me say, I don't care if you don't study. And I really mean that. Okay. Ashley, as a sub-spec, you have to study a little bit of your weak suit. Okay. But it's not like the written board where you've got to hit the books and read and read and read. Yeah, it's not so important. You've got to have a clinical response to everything. And so while you don't need to spend time studying like you did for the writtens, you need to use that time putting together a very effective, well thought out case list. And Lindsay, I have no problem with you just getting all the information down just so it's in there. But then you need to go through it like we're doing on each and every case. And look, it's taken us, I don't know, 20 minutes on average per case to do it. And in the beginning, the first 2 or 3 cases, it will take a long time, but it starts becoming very quick. And so I encourage you to do this on all your cases. Okay. All righty, let's take another one. Ashley, let me find it for you. There we go. What other case haven't we, do you want to go through? This, hold on, which one? Or is it
They're
mostly the
both very
same?
similar. Yeah.
Okay. Is it similar to the first case or not really?
Yes. Yeah.
So
it's very
these
similar.
3 are all basically the same?
Yes.
Okay, I'm just reading through. They really are pretty much identical. Ashley, I'm going to be honest with you. Everything that I said on the first case will be the same here. And to go through it individually, it'll just be a repeat.
Right.
So I'm going to say thanks for sending all your cases, but these 2, I think based on what we discussed in case number 1, you'll be able to handle cases numbers 2 and 3.
Yes.
Fair enough. Okay. So Ash, I'm going to pass on you then, and let's go back to Lindsay. There we go. Lindsay, here's
You
your
want
case.
to do, I gave like a little bit of each like category.
Yeah. So
Do
which
you
case would you like? You tell
Okay,
me.
do
You
want- should I do like the
whatever
office
you
one then?
whatever you want. You prefer to go to office?
Yeah, I guess so. Yeah.
Okay, no problem. All right. So let's read this together. 26-year-old gravid 1 para0 at 36 weeks and 1 day.
Wait, where are we? 'Cause,
Sorry, this is hypertension disorder pregnancy. Sorry.
oh, yeah.
I saw hypertension and I was thinking office, but she's still an OB case.
That's OB case.
That's-
Gynecological surgeries, it's
No.
probably at the bottom.
Oh, there it is. Sorry. Next page.
Yeah.
48-year-old gravida 2 para 2 bathroom cyst abscess.
Mhm.
Did an H&P incision drain word catheter, bacteria culture taken, Bactrim, 7 relief of pain, continued G1 care. Okay, it's a very straightforward case. Okay,
Mhm.
I just noticed ABOG misspelled infections on their website.
I think they transcribe.
Oh, maybe my secretary did transcribe. So
Yeah.
ABOG, if you're listening, I apologize. Okay, that was my secretary, I'm sure, because I had to ask her to transcribe it to a Word document.
Yeah.
Okay.
I wanted to look like the ABOG, so I had to copy.
No,
like the image.
that's totally fine. No problem at all. So Barthen's is a pretty straightforward issue. Let me start by the same principle. What kind of questions would you like to get on this case?
I mean, like I just now I'm thinking about like alternative management.
Are you talking about incision and drainage, word catheter, marsupialization?
Hospitalization, yeah.
Okay.
It was the first episode, so that's why we did the word catheter placement.
So we want to have a conversation on the different kinds of management of a Bartholin's gland and the pros and cons of each of those, yes?
Yes. Yes.
What about the following? Instead of saying IND word catheter placement, why don't we write optimize RX treatment in parenthesis word or word catheter?
Optimize, can you repeat that? Optimize what?
Optimized treatment or optimized management in parenthesis word catheter or word cath.
Okay.
Let's just write that down and see how it looks. Okay, we can always change it again. Optimized surgical management in parenthesis word cath.
Mhm. Or just word if it's too long.
Yeah, I think just word on its own.
Mhm. Or
How does
surge.
say again? Sorry.
Or instead of surgical, just write surge. And then write.
Well, we've got it on one line, but okay, I like it. I just want you to be word poor as a general
Mhm.
principle.
Right. And then you can write word cath.
Or
'cause
you know,
that's medical.
instead of optimized, optimal. Which
Optimal.
one?
Okay.
Optimal.
Mm-hmm.
Surgical word cath.
Yeah.
Yeah, it's on one line.
Okay.
Okay, and let's get a bullet in there.
Mm-hmm.
Just say cultures. We don't
Okay.
need to say the word bacteria, and we don't need to say the word taken.
Taken. Okay.
Cultures. The fewer the words, the easier it is for your examiner to read. Now, this is a general principle. It goes to you, Lindsay, it goes to you, Ashley, and everyone who's going to be listening in. With very few exceptions, and I can't think of one at the moment, if you've managed the patient with antibiotics, rather than give the specific kind, rather just say antibiotics.
Okay.
Because by putting Bactrim down instead of antibiotics, you've taken away from yourself and the examiner the opportunity for him or her to ask you, well, which antibiotics did you give? And that typically is a very straightforward kind of question, which most of us would be very comfortable to deliver. So I strongly encourage always, not just in this case, but just put antibiotics. You may sometimes want to say oral or IV, but don't be specific. So I'm going to change that now. And the actual one that you give and how you administer it, that comes in verbally, okay? How does that seem to you now, Lindsay, as we've written it up?
I think it looks more clean.
It's a lot cleaner. I think with the way we've written it, optimal surgical treatment word cath is very likely the word optimal is the key word here. That's going to suggest, well, what other options did you consider? Ashley, your thoughts on this case?
I agree. I think putting in the word optimal adds in that question of why it's optimal, and putting in antibiotics leaves the door open to be asked.
Exactly right. Exactly right. There's one other question, Lindsay, that I'm going to raise with you that you haven't addressed. And if you leave it like this, an astute examiner may well ask you of it, and you've got to be ready to speak to it. How do you know? First of all, you called it a cyst/abscess. Which one was it?
I think it was an abscess.
Yeah, I mean,
it was purulent.
If it's tender and red and painful,
Painful?
yeah,
yeah.
then call it what it is. Yeah,
it's an abscess. Yeah.
Now, in a 48-year-old, how do you know that this abscess didn't develop as a consequence secondary to an underlying adenocarcinoma of the Bartholin's gland?
Yeah, I should have done a biopsy.
in hindsight,
Yeah.
in a 48-year-old,
Mhm.
it would have been preferred. A lot
Right.
of people will not do it. Don't feel bad. Okay, I see this on case lists regularly. If the examiner asks you, how might you be able to speak to the case? I would say, look, I'm never, ever going to tell you folks to be dishonest and lie in the exam. Heaven forbid. I would never do that, okay? That being said, I think you would be comfortable without being dishonest to say, when I made the initial incision in anticipation of the word catheter, I was able to feel that there were simple loculations, but no solid area within the cyst. And had there been any area that was of concern, I would have biopsied it.
That's
How
true.
does that, see, it's true.
I
So,
like that.
okay, so now, you see, this is what you got to do with all your other cases, and you do it on your own. You realize, hey, I've got a problem here. I didn't rule out malignancy. How can I defend it? Okay, I'm going to defend it by saying there were no, outside of flimsy membranes, adhesions, there were no solid areas within the cyst. Now, if that's what I'm going to say, we're what I call reverse engineering the case. If that's what I'm planning on saying, how do I write the case up to get the conversation to a point where I can say there were no solid components within the cyst? You understand? So I want to add something here which will allow the conversation to go to a point where I can say, and there were no solid components here, because if there,
like a simple Bartholin abscess, like would that fix the?
I'm wondering, in the diagnostic procedures, I would write here simple cysts, or sorry, simple abscess, or I would say no solid component. What about that?
Okay. Okay.
Ashley, what do you think?
I agree.
Okay. No solid component. Okay. Now, with that down on paper, you can say why you commented on it and why it was relevant in this case.
Okay. So
And
what,
how
like physical exam, no solid components?
Well, I don't feel strong that you have to write physical exam. It's given. Okay. It's given. So this is, are you comfortable with this, Lindsay?
Yeah.
Okay. Ashley, how does it read to you? You're the examiner. What do you think?
I think it's good. Maybe saying something like physical or like PE physical exam dash no solid component.
Okay,
Yeah,
so
that's what I was thinking, like, I like
okay, so you both,
HMP.
okay, I have no problem with it. So or let's do PE, yeah?
Okay.
PE, no solid, how about that? Ashley, does that, any other recommendations to improve on that?
I like it.
You like it? Good. Lindsay, you're okay with that? Lindsay, you're okay?
Yes, I think that,
Okay,
I think that's
so,
fine. Yeah.
okay, good. All right. So look, just to show you now, Bartholin's gland is a very simple, folks. I'm relaxing. You can see my knees are up on the table. I'm not sitting like a formal person in a Zoom meeting. I'm just relaxing. My legs are up on the table. A Bartholin's gland is a simple, straightforward case. But even here, it took a minute or two to make a few subtle changes, and by doing this, you're swaying, you're swinging the basis of the case and the curiosity about the case to an area that you're just drooling, waiting for the examiner to ask you to clarify. And that's what we've done in this case, as well as all the other ones that came before. Make sense to you? All right. Listen, we've been going for about 1 3/4 hours now. I'm going to pause at this point, but I want to first. I want to thank both of you for volunteering. I want you to be totally, absolutely honest, and if you think this was a waste of time, I want you to say so. Be honest. Ashley, you first. What do you think about this session? Does it make sense? Do you feel it was helpful?
I think it's been very helpful. I think just little word choice changes are really helpful. And I think it's hard when I'm writing down my own case, I'm going through it, but to look at it from the other side and try and just tweak a little bit is good. So
yeah, let me just comment before I come to you, Lindsay. You don't know, Ashley, how right you are, because in one of my closing slides for the cases construction course, that this is going to be added onto that. I'm guessing you folks may have already registered for the first day of that course. I'm not sure, but in the closing slides, I say, look at your case list not from the candidate's perspective, but from the examiner's perspective, and that's exactly what you just said in essence. So, Ashley, very, very nice. Well done. Well put. And thank you. Lindsay, please, the same question I put to Ashley goes to you. Your honest opinion. Do you think it makes a difference? Did it help? Do you think it was worthwhile?
No, I think it was worthwhile. I'm still like at the point where I was like just transcribing, like after I do a case, put it on my list. And now it's like, okay, now I go back to that case and how to clean it up.
Yeah, that's exactly right. But now you've got a much better idea how to do that second part. And I think getting all the information down on paper is a good thing. You two should just feel very good. We're now roughly halfway through collecting cases for the year. And I can tell you, based on our experience, if 25% of people have started inputting their cases into their case list, that's a lot. So you're in the top 25% in this regard. So you're way ahead of the game. And the fact that you just put it in is a good thing. But now go back and tweak it so it suits you. What I've tried to do, and for everyone listening in, what you want to try and do, if I would have taken, Lindsay, your cases and tweaked them to suit Ashley, we would have come up with a different result, because she has different comfort levels and vice versa. So this is way to personalize your cases and make it the best possible cases it can be for you to generate the questions you want. That's the key thing. Okay. All right. Before we sign off, any last questions or comments, Ashley, on your end?
I don't think so.
All right. Lindsay, on your end, anything on your side, questions?
I haven't listened to all the lectures yet, and I'm sure you do talk about this, but when we make the case list, first of all, I'm assuming I should only stick to the minimum number that they tell us, or should I put all the cases that I've had for the year?
This is such an important question. Thank you for asking it, Lindsay. When it comes to office, you've got to choose 40 office cases. And I encourage you to do that right now. You can finish 1/3 of your case list in the next week. Go to your clinic shelves, pick out 40 interesting charts, and put in and finish your office section, and you're done. Now, with respect to OB and GYN, and I'm pleased we've got a sub-spec in the form of Ashley and a generalist in the form of Lindsay, because the answer is a little different. Lindsay, you've got to put down every, and this is in the ABOG bulletin, which I encourage everyone to check out. You've got to put down every patient that you deliver. And I will go one step further. If you admitted them and did the bulk of the like in a non-delivery admission, PID, third trimester bleeding, rupture of membranes. Those cases, rupture of membranes will typically have a delivery in it. But non-deliverable admissions, you should include those as well. And on GYN, if you did the surgery, you must in the delivery, you must include these cases. And if it was a non-surgical admission, PID, TOA, for example, you need to include that as well. Actually, for you, it depends if you're currently in a fellowship or you're post-fellowship. The rules and regs get a little specific. I don't want to give a one size fits all, except to say, check it up in the ABOG bulletin. What I mentioned to Lindsay is still relevant, but I'm under some circumstances, and I can't give you the specifics. You may only have to put down a minimum of 20 cases. For example, your FPMRS, maybe you only have to put down 20 cases of OB. I'm not sure. Okay, but you need to check it up because it is very specific and it does get fairly detailed for subspecialists. Okay.
Okay, so I have to put every delivery and every
so let me add a caveat. ABOG maybe 4 years ago or so changed, and they said if you have a normal delivery, and in the bulletin they describe what a normal delivery is, and in essence it's a person who has normal prenatal care, normal labor, normal delivery, good outcome for mom and baby, no complications. Those patients you don't need to list individually, and it makes sense because if you've got 40 complicated OB cases and 60 uncomplicated normals, it's just make it that much harder for the examiner to sift through all the normals to find the real meat on the cases. So it makes sense. So normals, as categorized, as defined by ABOG in their bulletin, you don't need to list. Now, I would say, just by the way, let's say there's a patient who was a normal, you don't need to list, but she happens to be Rh negative. Would you list that? Lindsay?
You mean it's Rh negative and the baby has Rh positive, so we give RhoGAM? Is that what you're?
Let's say both the mother and father were both Rh negative, just for the sake of the argument. So there's no what's the word I'm looking for?
I probably wouldn't.
There's no RC immunization issue going on here. Would
Right.
you put that down? Would you list that case?
I mean, I guess if you want to start talking about ASO immunizations and how this was not.
There you go. That's exactly right.
Yeah.
If you want to talk about RC immunization, then absolutely list it. Okay. And then in the treatment column, you go one step further. In this Rh negative mother, you write RhoGAM not given. And the examiner sees that, and he or she has to ask you, why the hell didn't you give RhoGAM? And there's your introduction to an RC immunization conversation. Okay. Let me take one which is a little more vague, middle of the road. Just a 16-year-old gets pregnant, everything else is normal. Would you include her on your list? Or would you leave her off as being normal?
You talk about teen pregnancy.
That's right. Do you want to talk about the risks associated with teenage pregnancy? If you want to have that conversation, you put her on. So it's up to you. You've got a lot of leeway there. Not all of those cases that are normal, you may want to just leave off. You may want to keep some of them on for the reasons that we've mentioned. It's up to you. You've got to be thinking all the time now, what conversations do I want to have in this exam? And with that in the back of your mind, you decide what you're going to include in the case of these normals on OB and how you're going to write up each case along the lines that we just spent the last 2 hours.
Okay.
Okay. All right, folks, I think that's it. Ashley,